Welcome to the Managing Emotions and Recovery webinar. My name is Christine, and I will be your operator for today's conference. At this time, all participants are in a listen-only mode. Questions will be taken via the chat feature throughout the program, as well as audio questions and answer sessions towards the end of the conference. Please note that this conference is being recorded. I will now turn the call over to Dr. Dennis Daley. You may begin.
Okay. Good afternoon, everyone, and thank you for joining us. You've made us very happy that you're with us today. What we're going to do is provide a brief overview of emotions, talk about the definition and why they're important, review the factors that contribute to different emotions, talk a little bit about emotions and health, emotions and mental health, and emotions as they relate to substance use disorders, and then some strategies to managing emotions. So we'll start with what an emotion is. Typically, the terms used are emotion and feeling are the same thing. When we talk about mood, we're talking about a more of a prolonged emotion. So you might have a feeling of sadness that continues and persists into a depressed mood, for example. And you want to think of emotion as one part of total health. In fact, I think I'm supposed to be operating the slides, I think. Okay, I'm sorry. When you think of total health, often we spend more time focusing on physical health and not enough on emotional health. But this is a big, important part of who we are. And when you think of health, you can think of the physical or the biological, the psychological and emotional, the social, interpersonal, family. These are relationships and connection, the spiritual. And I think some of us would even add financial health as well. And each of these affects the other. And so when you're talking about a feeling or an emotion, you're talking about how we think, how we feel, and how we're affected physically, and also what kind of impulses we may have to act on whatever it is we feel. And, so for example, you can take the feeling of anger, and you may have one person who basically suppresses it. They avoid it, they suppress it, they hold it inside. Someone else, they act on it impulsively, they don't think, they say or do whatever they want without thinking about the consequences. Now, if you look at this in terms of people that study cultures, they've identified some facial expressions for some of the common emotions, and they would be fear, anger, sadness, and enjoyment. Okay, next one. I'm trying to get to the next one here. Okay, and why are they important? They help us adapt to protect us. So, for example, anxiety or anger can help in certain situations, and you don't want to think about emotions as positive or negative because any emotion can have either manifestation. So, for example, those of us in the Clinical Trials Network, when we submit grants, there's a lot of intensity, there's a lot of work, there's a lot of anxiety, but often that anxiety leads us to working hard to get the work done. So that's a positive manifestation. However, if we felt so anxious we couldn't write the grant or get it done, then it would have a negative impact on us. Same way with anger. And I'll give you a personal example. I grew up in a lower income neighborhood, on and off welfare, public housing, basically in a poor family that was pretty chaotic. And as a young teenager and a young adult, I had a lot of anger, but I used that to set goals for myself and work hard towards achieving these goals. So it can help you or it can hurt you depending on how you react to how you feel. Now, on the other hand, and I think one of the problems in our culture is we're so focused on the negative, and I think this is true in the treatment of addiction and the treatment of psychiatric illness or the combination. We focus a lot on pathology, problems, and symptoms, which is okay to a degree, but we don't focus enough on positive emotions, and so we will talk a little bit about this. But clearly, emotions are important because they enrich our life. If you don't have love in your life, then I can't imagine what it must be like for you. Love, gratitude, these things are very important. They add a lot to how we feel about life. Each of these we already mentioned, each area may affect the other. And again, related to addiction or related to mental illness, how people feel and how they cope with the feelings can either aid their recovery or impede their recovery. And when we're talking about recovery, we're talking about essentially managing your disorder, your disease, be it cocaine addiction or major depressive illness, and making changes to help yourself and improve the quality of your life. Now, Dr. Douaihy is going to talk briefly about what contributes to our emotions and mood.
Thank you, Dr. Daley. Good afternoon, everybody. So if we look at the slide of the contributing factors, obviously we need to understand emotions or emotional states as really multifactorial, and there are multiple contributing factors here. And as you can see from the slide, there is obviously the biological factors, psychosocial factors that would obviously incorporate a lot of really the behaviors, the life experiences, as well as also values, beliefs, goals, accomplishments. And this happens in the whole context of really the interpersonal piece, because you see a lot of people who end up with a lot of interpersonal conflicts, for example. This could potentially lead to a lot of negative emotional states, and we're going to discuss that a little bit more when it comes to the relapse prevention piece and the triggers for people who have substance abuse problems, and mostly they are really very much intertwined, the interpersonal conflicts with the emotional states. But as I mentioned, all these factors are very much intertwined, and in order to really understand people's emotional states, we need to incorporate an understanding of all these aspects. The next slide is about really the importance here of what I mentioned earlier is the interpersonal piece. There is a common thread here when we talk about emotion of really the experience that happens when we are with other people. When we are with other people, we are present with other people, and as a part of that, we are present particularly with patients, and we are present with patients because we care about them, we want to work with them, we are there to collaborate with them on whatever they believe is really important for them to focus on. And a big part of what we do, which is really the feelings of connectedness, comes through helping the patients share their experiences and their emotions. So a big part of the whole process is really to facilitate patients' abilities to share their experiences that are obviously full of emotional states. And obviously, as we know, also the common thread is that through the feelings of connectedness, we're talking about the presence with the patient is really that closeness, that genuineness, obviously the caring aspect, the love, and the altruistic values. Emotions are all across cultures experienced, obviously in different ways. They are, in fact, the categories are really clustered the same. So there are no really differences in terms of really the emotions per se. Obviously, the experiences of the emotions could be very much different. But in terms of really all across cultures, emotions are really universal, and they include anger, depression, sadness, fear, enjoyment, there's shame, disgust, the surprise, love. So there is a whole spectrum of emotions that we can see. Dr. Daley has mentioned earlier about the importance of not labeling emotions as positive or negative experiences, because obviously it depends on the psychosocial context of where the emotional state is felt. Obviously, there are really situations where we identify emotional state as negative. For example, depression. This is really very well established, or emotional state of shame, let's say. This is well established as a negative emotional state. But again, it's always important to really understand it in the context of how it's felt, how it's been experienced by the patients. And for example, the anxiety and the fear reactions can lead to really positively to some vigilance or action or avoidance, and also the anxiety could be sometimes really paralyzing and lead people to not being able to function. So also in the context, particularly also with patients who have substance use disorders, the anger or the shame or the guilt could be motivating factors for patients to make a change, to stop using, to work their recovery. At the same time, they could lead to relapses and substance use, or they could also lead to violent behaviors or even suicidal behaviors. So the other thing is, for example, the depression or hypomanic symptoms or hypomanic states. They can also lead patients to becoming more creative, and at the same time, they could be, on the other hand, lead people to suffer and really not function well, and definitely affect negatively their quality of life. And we know also very well when it comes to the settings of behavioral medicine, a lot of patients who are dealing with chronic medical illnesses, when their emotions are poorly managed, whether emotions of depression, anger, frustrations, they can easily affect their physical health as well, obviously, as their emotional health, and also will affect the interpersonal relationships as well as the quality of life. So here is when we started on conceptualizing emotions or the moods as problematic, how we would define that. There are different ways of looking at it, and as I mentioned, it's always happening in a particular psychosocial context and situations. And when the emotions are too intense, extreme, or chronic, long-standing, when they lead to problematic behaviors, particularly we would focus on that more in details when they have a significant negative impact on relapse or substance use, which obviously, as we know, negative emotional states are the #1 trigger for relapse in patients who have substance use disorders. And also when it has an overall impact on the emotional health, as well as obviously the physical health, we need to keep that in mind. And also when the emotions and the feelings are a part of a psychiatric disorder, such as depression, anxiety disorder, or personality disorders, or any other, even psychotic disorders. Very briefly here, we don't have much time to discuss that. This is a whole field by itself, is the connections or the understanding of the emotions and the brain, and particularly the brain functions or some structures in the brain that really modulate the emotions. And two major parts of the brain, the prefrontal or frontal cortex and the amygdala, that I would like to very briefly focus on, and these are basically parts of the brain that have been very much also a part of the neurocircuitry of the addiction, and also part of the neurocircuitry of a lot of the psychiatric disorders. So a lot of the psychiatric disorder and addictions are really affect these areas of the brain, and these areas of the brain affect obviously the process of relapse to the psychiatric illness or to the addiction, and as well as the other way around. So in terms of the frontal cortex, we know clearly that the information that we have, usually it goes from the limbic system to the frontal cortex to produce some specific conscious feelings, that emotions. And very much important to think of what we are going through. Our environment is fed, the information that we have there and the knowledge that we have there is fed from the cortex, from the prefrontal cortex, as you can see it on the picture there, to the limbic system in a very much of a closing loop. And we know clearly that the effects of the emotion on the thoughts is very much stronger and more significant than the effects of the thoughts and the emotion. And this is really important to keep in mind. For example, when we are working with patients, particularly on cognitive behavioral approaches, is we always get the patients to start understanding the impact of their emotions on their thoughts and the other way around, and how to really help them better control their emotions and also really address their distorted thoughts. And so obviously you can see here the connections, as well as obviously the ultimate really outcome also is on the behavior. The amygdala area in the brain, as you can see it there, is really not completely clearly defined. It's a structural area at the same time. It's really more of a functional area, and as you can see there also, as a part of the the nucleus accumbens and the VTA are also basically structures of the brain that are very much connected to the neurocircuitry of addictions and other psychiatric disorders. So the amygdala is very much important. It's really most centrally concerned with the emotions and the feelings, and it is a place where it does assess the external and internal signals or stimuli. So for example, we talked about really the fear that happens when you're really in a situation where you really feel in danger, you react with significant anxiety. And so it really helps in a sense produce more appropriate emotional reaction, as I mentioned, with the anxiety. At the same time, sometimes if the amygdala is very much affected, for example, by the addiction, the emotions could be not very much appropriate as a response to being affected by using substances. The positive emotion
I think Tracy
yes.
and I, we're both doing it together.
Yeah. So the limbic system here, as I mentioned, structures, they are very close to the amygdala, and they are very much involved in the feelings of pleasure, which, as I mentioned, is a part of also the neurocircuitry of the addictive disorders. And we know also very well that the activity there, in a way, the neurochemical activity that goes on there could be reduced in the amygdala and other really cortical areas, as I mentioned, particular prefrontal areas, is really associated with anxiety. And as I mentioned also a little bit earlier, there is very much a close connection between the anticipatory reaction as well as the pleasure-seeking areas, and they are very much influenced by the reward circuit, as I showed earlier, which is the VTA, nucleus accumbens, and the amygdala, and the reward circuit there, which is really very much involved in the neurobiological aspects of addictions and other psychiatric disorders. And always keeping in mind that this does not happen, as I mentioned, out of context. It happens also with the impact on really the memory, the impact on other areas in the brain, particularly, for example, the hypothalamus and the amygdala, that also, in a way, contribute to the neurochemical changes and really secretes a lot of the neurochemicals, neurotransmitters in the brain, including dopamine, GABA, and serotonin, and other ones that are responsible for either worsening some of the symptoms, for example, of addictions, or impact on emotional states. So this is one thing I would like to really mention here. We don't have much time to discuss that, but is really again, within the context of understanding the emotions and the brain, the social brain hypothesis. I'm not sure how many of you are familiar with that. It's been really an interesting hypothesis, and the hypothesis is that the brain has the ability to manipulate information, not simply remember it. So it's a very much of a complex task that the brain has, and it does involve a lot of really basically the functions, whether we talk about sex, whether we talk about love, survival. So it's really, in a way, the brain has evolved throughout the years to deal with essentially a lot of what we call more the ecological problem-solving tasks that are obviously very much tied also to the emotions. Other factors, for example, the oxytocin, is basically it's a hormone that is produced and released during sexual activities and in final stages of childbirth that is seem to have been also connected to the feelings of pleasure, feeling good. And that also one of the factors that is really involves changes that we see also with patients who have whether psychiatric disorders or even addiction problems. The insula, this is the area of the brain that is also very much a functional area too, that really defines that part of the brain that really is the moral part of the brain, which really helps people see what their values are and what defines really the right things from the wrong things, and obviously that also includes also some aspects of the empathic approach or the sympathy approach. And interestingly enough, with patients who have antisocial personality disorders or psychopaths, and they show some signs of low activity in the amygdala on the imaging studies, and which really obviously indicates that these patients have really obviously struggles with what we call really the moral values, and that's why they have a complete disregard to a lot of patients' feelings and emotions, and they lack basically the empathy for other people. So defining now really since we're going to talk more and more about really the context of the emotions, the brain functions, and the addictions, substance use disorders. So any sort of drugs of abuse, they engage systems in the brain that involve the motivation and the pleasure pathways that I mentioned earlier. So here we're talking about really very much of a complex disease that really involves a lot of the neurocircuitry in the brain that produces a lot of the emotions and that dysregulates, in fact, emotions, which, as we know, in the most fundamental struggles that patients who have substance use disorders go through is how to regulate their emotions. And we also see that particularly in patients with other psychiatric disorders. And you can imagine when you have patients who have substance use disorders co-occurring with psychiatric disorders, that obviously can complicate the whole picture.
Okay, we want to move into talking about emotions and health, and I think Dr. Douaihy and I both had alluded to this before. You can't separate physical or spiritual health or relationship health from emotions. They're all kind of intertwined. But again, if you look at this from the broad point of view, you can look at well-being from all these different dimensions, which we had mentioned before. But I want to point out the third point on the slide, which is emotional well-being. And the way this is defined by some is the degree to which certain emotional states are experienced. And the groups that are seen as causing the most difficulty to the largest number of people would be depression and sadness, because keep in mind in our society we have high rates of clinical depression, anxiety and fear. Also keeping in mind you have higher rates of anxiety disorders. In fact, anxiety disorders, the prevalence is higher than depressive disorders. And then anger and hostility. And again, you could look at any of these in terms of the degree to which a person's affected, but the important issue is how this connects with other areas of health. Now, if you look at, there's a significant literature on aging, and the people that age the best and do best, I mean, obviously you have to have good physical health, not if you have a chronic disease it has to be well managed, but if you have good defensive, good skills in managing your emotions, good social networks, these are just some of the factors that help promote longevity and increase how long we live. So George Belliot and many others have written, I think, some very interesting books and papers on this area. And some of just a few things I wanted to mention is there are a number of studies that have shown that if you have depression or anxiety, it's a risk for heart disease. If you have high levels of anxiety or hostility, it can predict not only heart disease, but it can predict a second episode of some event, related to your heart. So clearly, these may be just a few examples, but there are a lot of other examples of how health is affected. Now, back in the 1990s, about mid-90s, there was a psychologist, and I think he was may have written for the New York Times, Daniel Goleman, and wrote a book on emotional intelligence. Now, what he did was he took the work of a lot of psychologists and a lot of researchers, and I thought did a superb job integrating the book. And in fact, there have been a number of subsequent publications called Working with Emotional Intelligence and How This Applies to the Workplace, and Social Intelligence, How This Applies to Interpersonal Relationships. And what he promoted was the importance of emotional intelligence and success based on all the different studies. We tend to be a society in which we value intellectual intelligence, high IQ. But what Goleman and others are reporting that is just one factor in our success. The larger factor is what's considered emotional intelligence. So we all know people who are extremely brilliant, but when it comes to relationships and getting along with people, they don't do so well. And that can certainly interfere with their success, whether they be a researcher, it doesn't matter what they do. And when they define emotional intelligence, they're talking about different characteristics. And in a sense, what they're saying is that if people are emotionally intelligent, they're going to do better in life, regardless of what they do. And what this means is you can manage your emotions, you can regulate them, you can experience a range of emotions, and you can control your impulses. I mean, we've all been very upset where we wanted to say or do something that wouldn't be in our best interest or the best interest of other people. But from a healthy perspective, mature perspective, you don't act on your impulse. You do what's best in the situation. Whereas you have other people, and you see this a lot with addiction, where they have trouble controlling the impulses. If they feel something, they let it out. Another part of this is awareness of our own emotions. And what I forgot to mention early on is that emotions can be primary or secondary. So, for example, Anger can be a primary emotion or it can be secondary. Underneath anger can be hurt, can be sadness, can be depression, could be grief and other things. Emotions could be in your awareness or out of your awareness, so they're not always conscious. They can also be mixed. For example, it's very common, if you look at psychiatric disorders, it's very common to have mixtures of depression and anxiety. You see that also with people in recovery from addiction. Depression and anxiety often go hand in hand. So awareness of emotions is important. It's easier said than done. But not only of one's own emotions, but the emotions of other people. Being able to read, what are other people might be feeling based on their facial expressions, tone of voice, what they say or what they don't say. So reading other emotions of other people is certainly a skill that, in my honest opinion, many of us lack. Another important area here would be to tolerate frustration and pursue goals. If you talk about this in the context of addiction recovery, any person in recovery is going to have stressors thrown their way, problems thrown their way. There's always a reason to go back into using drugs or alcohol, but they have to look at how do I tolerate these difficulties, these frustrations, and still pursue my goal of being sober and doing the other things I have to do in life. Another important area is empathy to others, understanding what it's like. And what we always stress in our teaching of residents and medical students and professionals is the more you can understand the experience of addiction or mental illness, walk in their shoes. What is it like to have schizophrenia? What is it like to have recurrent major depression? What is it like to want cocaine so bad that you would sell your children's clothing or your children's food to get $5 for crack cocaine? The more you can understand what it's like for another person, the more you can be empathic, because empathy certainly leads to healthy relationships, and it's good for all of us. And in fact, that's one of the important aspects of a therapist, is to be able to be empathic towards his clients. And then another characteristic is expressing positive emotions. We tend to be too focused, I think, in our culture on negative emotions, not enough on positive. And I think, we all go through this. You have to consciously pay attention to positive emotions and sharing them with others. Now, in terms of emotions and mental health, briefly, and the first 5 points really actually came from the characteristics related to borderline personality disorder. But if you look at the third point, there's a tremendous struggle with emotional regulation. And with the person with borderline disorder, they'll often abuse drugs or alcohol. They'll have interpersonal problems, all kinds of conflicts, arguments, fights, ending relationships, threatening people, threatening themselves, hurting oneself, depression, anger, emptiness. And a big intervention with dialectical behavior therapy used with this disorder is helping people regulate their emotions to increase positive and decrease negative emotions and the related behaviors. Now, if you look at this briefly in terms of axis 1 and 2 disorders, depression is common with many of the disorders. So is anxiety, and so is anger. Many people with depression or anxiety disorders have issues with anger, but they tend to have issues relative to suppressing it. Now, on the other hand, when you look at axis 2 disorders, which are personality, you have anger and boredom and emptiness are very common. And I think that the two most common disorders we find with those who have addictive disorders would be borderline and antisocial. And so anger is common. Now, the difference is with the borderline, person with the borderline disorder, they'll often take out their anger on themselves. They'll burn, they'll hurt themselves, whereas the person with the antisocial will take it out on other people. They'll threaten, they'll do physical violence and things like that. The other common issue would be boredom and emptiness, which is common with those disorders. And we'll talk a little bit later about boredom, but I would say, I think, in my opinion about recovery from addiction, one of the challenges people have is having a sense of meaning and having a sense of direction. And I think when people have the sense of emptiness, and you don't have to have an axis 1 or 2 disorder to have a sense of emptiness, those who lack direction and don't have a sense of meaning have more difficulty in their recovery. And the meaning, that can come from anything. It can come from relationships. It can come from religious beliefs, spirituality. It can come from avocation, hobby, creative tasks, and things like that. And related to substance use disorder, and actually the quote here is more for depression. This is F. Scott Fitzgerald, those of you who like American literature. I could lie around and was glad to, sleeping or dozing sometimes 20 hours a day. Every act of life, from the morning toothbrush to the friend at dinner, had become an effort. When you get into the experience of depression or anxiety or any intense emotion or mood, it conveys the suffering that people go through. Now, with substance use disorders, they're common with mood disorders, they're common with anxiety. They increase the risk of these other disorders. They also increase, when you look at something like anxiety, because of the way people try to cope with anxiety, it increases the risk of dependence on certain kind of medications, especially the benzodiazepines, where people with anxiety will often doctor shop or go or really push hard to get medicine to feel better. And that's sort of I think a way our culture deals with many issues, which is, take a pill and feel better. Not that medications can't be helpful, but you can certainly over-rely on them as well. Now, in terms of anger and addiction, substances can cover up, they can distort, they can bring out feelings. We have patients say, well, when you're drinking, does your true feelings come out? Yes, they may come out, but they may be exaggerated. So you can be mildly irritated with someone, you could be drunk, and it can come out as intense hatred or hostility. Many of you know we lost a good colleague and friend, Ellen Marlotte, from the University of Washington about a year ago. And Dr. Marlotte, to me, I consider him the grandfather of relapse prevention. He was the first one really to write about this, research about this, published the first book in the 1980s called Relapse Prevention, probably is the book most cited in the addiction literature. And he published a number of studies where they looked at different addictions, alcohol, heroin, smoking, they looked at gambling, they looked at compulsive overeating, and they looked at these different categories. And if you look at what he found, and many others have found this as well, is that if you look at alcoholics as one subgroup of the addicted population, negative emotional states was the most common problem identified as associated with relapse. However, having said that, what we want to point out is it's not the emotional state itself, it's whether or not do I have the ability to cope with this. It's the coping skills. And that's an important part of recovery, because many people in recovery are going to feel anxious or depressed or bored. What do I do with this? Do I have the coping skills? And that's one of what we focus on in helping people learn to manage their emotions. Okay, so I see we have here a question mark. Any questions? I'll take a look here. If you have any questions, you can write them in, or you can tell us on the phone.
Thank you. We will now take questions. To ask a question, please press star then 1 on your touch-tone phone. Once again, that's star then 1 on your touch-tone phone for any audio questions. Currently at this time, there are no audio questions.
Okay, and I didn't get any on the, all right, I didn't get any on here either. So, okay, we'll go ahead and continue. You might not have questions, but we have answers. We don't know what they are, but we'll look for them. All right, so let's go to the next slide. And if you haven't met Dr. Douaihy, that's his picture in the middle of the slide. You got a haircut since then, huh? So in a kind of a broad, general sense, when you're talking about the strategies of managing emotions, we're talking about decreasing the negative ones, the degree and the frequency and intensity, increase positive ones, and helping clients or patients learn some general coping strategies. There may be strategies specific to a given emotional state or a mood as well. And so, for example, when Dr. Douaihy talks, he'll talk briefly about mood and anxiety disorders and talk about some of the strategies used to help those in terms of treatment. Now, we do a lot of quality initiatives to find out. Our best teachers are our patients. So we did a study in 2006, and we wanted to find out what the greatest challenges are among patients in terms of their recovery. And these are the different categories. The one that was rated the most often was managing emotions. And some of it was general, just managing emotions in general, but they also identified all the ones we had listed before, which would be, with the addiction, it would be mainly anger, boredom, anxiety, depression, and guilt and shame, and to a lesser extent, well, and also for some of them emptiness as well. So they thought that was the biggest challenge. And what we did as a result of this, Dr. Douaihy and I are real big in dissemination information for patients. We developed some interactive recovery guides to help patients learn about and learn some of the coping skills to deal with these different emotions. Okay? Now, if you look at the substance use, the different treatments, the evidence-based treatments, and these are just a few. You have 12-step facilitation, CBT or coping skills. You have individual drug counseling, group drug counseling. You have the matrix model, recovery training, and others. If you look at the details of these different treatments, and most of these, well, actually, half of them are individual-based, half of them are group, and some have combination. The emotional issues they address the most in the addiction therapies would be anger, boredom, guilt, and shame. You see less focus. That doesn't mean they don't focus on other emotions, but you don't see as much focus on anxiety and depression and things like that. It's more sort of the guilt and shame, boredom, and anger. So just something to be aware of. I think it's, clearly you have to focus on what patients need help with. But these are so common, you can almost develop a core curriculum where you teach these, all the patients, how to manage these certain emotions. And the sort of the way to think about this is to help people determine what feelings are high risk for them, because anger is not a problem with everyone. Neither is boredom or depression. And what are their current coping skills? And remember, when we ask people to stop using drugs and alcohol as part of treatment, in a sense, they're losing one of their coping skills. That's a great way. It's not an effective. It's not a healthy way, but it's been a way people have coped with a lot of different upsetting emotions, the whole range that we had talked about. And so we want to look at, can we help you with some of your existing skills or develop new coping skills to deal with your feelings? And then, very importantly, because there's high rates of psychiatric comorbidity, we want to, there are a couple extremes you want to avoid. One is, we want to slap on psychiatric labels just because people have symptoms. You have to look closely at the history, the intensity. You have to separate as much as you can. How much of this is mood or anxiety? How much is it related to the substance use disorder? But you don't want to also take the other extreme in which you expect people to have significant periods of time off of drugs or alcohol before you determine if a mood or anxiety disorder exists. Because keep in mind, these comorbidities are very high, among those with substance use disorders. So you want to make sure you consider that. Now, what we're going to do is we're going to take the last part of the seminar, the webinar, and we're going to talk, we're going to pick a number of the common emotions and just talk about some strategies. And well, I think we do this kind of alphabetically. It doesn't mean that anger is the most important. I think we just did it alphabetically. And these are some terms used: mad, angry, upset, miffed, pissed, steams, and so forth. And in addiction, what you see is what's fairly common. If you look at this on a continuum, on one end of the continuum, you have the folks that Dr. Douaihy had mentioned before, who act out everything impulsively. They may be wired differently. Who knows? These are folks that they're not all antisocial, but you certainly have folks who have antisocial traits or disorders who are more likely to say and do whatever they want when they're upset and angry. In fact, they will use it to control people, to make people do things for them. They will use it to push people away and to get what they want. And then you have on the other end, you have people that what they do is they kind of hold on to everything. And if you look at this on a continuum, typically it's most helpful for the people on the one side who act it all out. We have to teach them to put a lid on it. They have to learn to control it. It is not always good to express your anger. In fact, there are many cases in which it's better to help people contain it, because if you let people let it out too freely, it'll work against them. And so with drug and alcohol problems and addiction, that can cover up, distort, or bring out the feelings. It can contribute to relapse. It can contribute to severe interpersonal problems such as violence. We know that being a perpetuator or a victim of violence is higher if you have a substance use disorder, and it's often expressed inappropriately. And I had already mentioned the extremes of acting out or holding it in. And so if you look at basically some strategies on anger. I like this little cartoon here. But the only time I get mad is when somebody pisses me off. I don't know who creates these things, but they're pretty cool. And you have a number of different strategies, and I think this is true for a lot of the different emotions or feelings or even mood states. But the caveat we want to mention is that no one strategy works for everyone in the same situations as well. So you really need a variety of strategies. So with anger management, you really have to start by helping people recognize their anger. And really, should they be anger? Is it justified? Often it's not justified, because you have a subgroup of addicted people who get angry about every little thing, and they really need to change how they think about the world and think about other people. So part of it is changing the beliefs, changing how they think, also looking at how are they affected by these methods of expressing. So if you get angry at your children and you talk with them about your concerns in a controlled manner, in a respectful manner, you'll have a better outcome than if you cuss them out and yell and scream at them. Because the way you come across will have an impact on other people. So clearly you need a number of strategies. Some are cognitive, some are behavioral, some are verbal. One of those of you who have ever studied the work of Marsha Linehan in DBT, dialectical behavior therapy, one of the really cool strategies that she teaches with the patients who have this disorder is to act the opposite. So if you're angry at someone, be kind towards them. Don't be pissy. Don't be confrontive with them. That sort of thing. And then you can also look at, there are a number of many direct strategies. Talking with other people, talking with the person, talking about the problems. But there are also indirect strategies too. You have people that work out. Physical activity is good. Creative activity, it could be drawing, it could be writing, it could be journaling, all these things. And then the other thing I wanted to mention is what we do in treatment sometimes, because this is a significant issue with a number of patients, is we do behavioral rehearsals where we will set up common scenarios in which they feel this anger towards someone, and we'll role play, and we'll teach them different ways of expressing what they need to express, but in a healthy manner. We're going to turn to anxiety, and Dr. Douaihy is going to talk about anxiety, and then that will be followed by depression.
Okay, thank you, Dr. Daley. So I'll be reviewing the anxiety and the depression, and so let's see if we can. I'm trying to read more. Okay, so this is extremely important to understand the anxiety as obviously an emotion as well as an emotional state, and also understand that it can be a part of a disorder. And keeping in mind here that a lot of the anxiety disorders most of them, I would say, put patients at risk for using substances, and the other way around. A lot of patients who have substance use disorders could have co-occurring anxiety disorders. In fact, the two anxiety disorders that are the mostly seen in patients with substance use disorders and or the other way around, like mostly the substance use disorders that we see with patients who have anxiety disorders, for example, alcohol. Alcohol dependence happens very commonly in patients who have a panic disorder, and the reason is because obviously patients initially relying on using the alcohol to deal with the anxiety and seeing some benefits from it, and then later on, eventually, if they have the vulnerability, predisposition to becoming addicted to alcohol, they end up with a full-blown alcohol dependence on top of the anxiety, on top of the panic disorder. The other one is, for example, PTSD. It's very highly comorbid with substance use disorders. And one important issue when we're looking at anxiety disorder and substance use disorder is that a lot of patients also can very easily become addicted to some particular medications. For example, the tranquilizers, the minor tranquilizers, which is the sedative hypnotic category, which is obviously the benzodiazepine, that are used sometimes to treat some of the anxiety symptoms or some of the anxiety disorders. And in patients who have substance use disorders, that could be very problematic because a lot of the patients either become addicted to these benzodiazepine, or their use of benzodiazepine could put them at risk for using other substances of what we call the substances of origin that they've used before, whether it's alcohol, opiates, or cocaine. So always remembering to keep in mind that when we're treating patients with benzodiazepine, patients who have substance use disorders or other anxiety disorder, treating them with benzodiazepine is very risky practice, and we need to really always look at other options and alternatives first before we use the benzodiazepine medications. And keep in mind that patients who have anxiety disorders also have very limited ability to tolerate and cope with the stress. And this is one of the reasons why they want sometimes to rely on the quick fix. And the quick fix is usually a medication. And unfortunately, the quick fix, the medication is usually benzodiazepine. And there is sometimes a major struggle to get patients to see the importance of the therapeutic interventions, non-medication interventions that could be as effective, not even sometimes better, than really using medication strategies. And so a big part of working with patients who are struggling with substance use disorder, anxiety disorders, is to really emphasize the therapeutic strategies that they can work on than to really just rely on the medication piece. So here, in terms of what psychological treatments we have available for a lot of these anxiety disorders, first of all, the panic disorder, whether with or without agoraphobia, there's the exposure therapy. Cognitive behavioral therapy is another one that is really very much helpful. In fact, the CBT is really can produce very, very positive effects, particularly when patients complete the CBT treatment. Obviously, it's a very much of a treatment that is really relies a lot on basically a lot of the homework, and also it requires a prerequisite for that patients be motivated to really do it. And for the patients who do not have much of that motivation to do it, obviously incorporating a lot of the motivational strategies to get them more motivated to do the work and the therapeutic work, would be helpful as an adjunct to the CBT. The social phobia, that obviously there are different strategies that are used, whether exposure therapy, CBT, social skills training. And one thing I wanted to mention here, the social skills training is unfortunately underutilized in the treatment of substance use disorders, particularly with people who have anxiety disorders and other psychiatric disorders that are co-occurring with it. And in fact, the social skills training is extremely important, and it should be a part of the psychotherapeutic strategies that are used. And it can basically help a lot of the patients learn coping skills, learning different approaches to dealing with particular psychosocial stressors, the interpersonal problems, and so again, this should be a part of really incorporating that. A lot of patients who have social phobia, which obviously gets them extremely anxious when they are around other people, whether sharing or really being scrutinized around people. Particularly with patients who have substance use disorders, they may become very much resistant or reluctant to consider going to mutual help groups, and the reason is because they feel extremely uncomfortable in social settings. So we need to keep that in mind and make sure that this is really addressed with patients, because sometimes we have a tendency when we ask patients about their involvement in mutual help groups that when they tell us they are not doing it and they don't want to do it, and we need to always explore the reasons for that, and always keeping in mind that if they have some social phobia symptoms, that could really basically be the contributing factor for them not adhering to the mutual health groups. The simple phobia is, again, usually not really seen as often, with substance use disorders, but obviously the treatments are not much really different than the exposure therapy and the cognitive behavioral therapy. The generalized anxiety disorder, which is really also very often comorbid with substance use disorders, in fact, the best treatment for that is really the cognitive behavioral interventions, and obviously the use of medications can have a role here, keeping in mind that using the combination could be potentially more beneficial. The rest of them, the OCD, the obsessive compulsive disorders, obviously the different therapeutic strategies incorporate exposure therapy and CBT. Usually patients with OCD, I've seen that in my practice, they have a tendency to get to rely on alcohol to deal with a lot of the obsessive symptoms, and I've seen patients in fact getting addicted to the alcohol. In that context, we have to always remember that when we're really treating patients who have anxiety disorders, to screen and assess for substance use disorders and treat aggressively along with treating the anxiety disorder. In terms of the PTSD, the post-traumatic stress disorder, the therapies that have been well established, obviously it's different versions of this, cognitive behavioral therapies and trauma therapies. In the context of patients who have substance use disorders co-occurring with PTSD, a CBT that focuses on both is really very much beneficial, and the seeking safety approach, which is really incorporates CBT interventions as for the substance use disorder as well as the PTSD, and it's very much of a manualized treatment. And there are other basically models that have been used and that really are mostly based on incorporating cognitive behavioral interventions for both the PTSD as well as the substance use disorders. The role of the medication is extremely important in treating patients who have anxiety disorders. As I mentioned earlier, we need to be clear with patients about the importance of the psychotherapeutic approaches as well as the medication, and really using them in combination. And a lot of the medication that are really used, I'm not going to get too much into the details, but we have a lot of medication that work very well, that improve significantly the symptoms of whether panic disorders, GAD, social phobias, and PTSD. And so the ones that, for example, for the panic disorders, we know the first-line treatments include the specific serotonin reuptake inhibitors. We're talking about fluoxetine, sertraline, and other the SSRIs. And obviously there are other also medications that include the tricyclics and the MAO inhibitors and benzodiazepine. As I mentioned before, we have to be extremely careful about the use of benzodiazepine in patients who have comorbid substance use disorders. For the generalized anxiety disorders, in fact, the SSRIs have become more and more of the first-line treatment. Obviously, the use of venlafaxine has been very much beneficial too, which is another class of SRIs, another class of antidepressants, and obviously the buspirone that is also that can be used. The other one, in terms of the social phobias, there are also the SSRIs do work in the TCAs. Again, keeping always in mind that the benefits from the medications could be optimized if the patients are involved in therapy. This is for the OCD. A lot of the SSRIs are the first-line treatments, including Prozac and Zoloft, which is obviously fluoxetine and sertraline, and other medications, the TCA, clomipramine, which is anafranil, and fluoxamine, which is the Luvox. And for the PTSD, we have been using mostly for the first-line treatments the SSRIs, including the sertraline, which is Zoloft, and fluoxetine, which is Prozac. In regards to the substance use disorders, we have a few medications that we've been able to see some benefits from. It includes the opioid antagonist, the naltrexone, which has a couple of formulations now. There is a pill formulation and the injection formulation. There is the acamprosate, which is Camprol, that targets the alcohol. For the naltrexone has been indicated now for the alcohol dependence as well as the opioid dependence. And we have the replacement treatments that include the methadone and buprenorphine for opioid dependence, as well as replacement treatments for the smoking, the nicotine dependence, which includes obviously the patch, the gums, the lozenges, and also other medications that have been used, such as the bupropion and varenicline, which is the Chantix. In terms of the cognitive interventions, which are really the mainstay of the treatments, for the anxiety disorders, this is really an interesting quote from Mark Twain, that really emphasizes, looking at, in a way, the glass half empty. versus the glass half full, and he said, like, I'm an old man, I have no main troubles, but most of them never happened. And a lot of the patients that we see, particularly a lot of patients that we see who have substance use disorders, have also a tendency to really be very much, particularly after they've been clean for a while and end up using it again, perceiving their relapse as really very negatively, beating themselves up over that, and really leading up to more negative emotional states, including anxiety, which keep them in a way stuck in that vicious cycle. And big part of really working with them using cognitive behavioral strategies is to help them change the way they think about the relapse process, like reframing, how they think about it, from really a failure to a learning experience. And a big part of it is really getting them to see it more like from the glass half full, with what they could do now to really minimize the risk of relapsing again and to prevent it as much as they are able to do. So a lot of what the use of the self-talk has been really very much helpful for a lot of patients, that really, again, get them to see the anxiety symptoms as more from reframing the way they think about it, and which is, again, as I mentioned earlier, the big part of the cognitive behavioral approaches is to get people to address their cognitive distortions that lead to negative emotions and also particular behaviors. So working on all these components is extremely essential. These are some of the slogans here that would help people sometimes really reframe the way they look at anxiety. In terms of the intervention, as I mentioned very briefly, the exposure therapy, that in the sense how it really works in a way, is a lot of behaviors that contribute to social anxiety include avoiding particular specific social situations and feared situations. In fact, what the exposure therapy would really provide is really breaking that vicious cycle of avoiding social situations and learning how to deal with that anxiety when it happens in these particular situations that they tend to avoid. So moving on to the depression and the mood disorders, and obviously this is a very much of a broad topic. I want to really be very much concise and practical here. So as we know, if we look at the depressive disorders, the context of it, we have different types of depression. We have the major depressive disorders that could be single episode or recurrent episodes, and we have the chronic depression, dysthymia, and also we have what we call the double depression, which is patients who have the dysthymic disorders, and on top of it they have episodes of major depression, and also different other types of atypical depressions, such as really the depressive disorder not otherwise specified, that could also include brief depressive episodes. And also we have a lot of depressive episodes that are induced by substance use or other medical conditions. So in terms of what the treatments are, that incorporates psychotherapies, medication, and electroconvulsive therapy. One thing I want to point out here about the treatment of depression, obviously the treatment of depression has been now mostly determined by also the level of depression. People who have a mild to moderate depression seem to benefit mostly from therapeutic approaches, psychotherapeutic approaches, than really just medication. And the people obviously who have the more severe forms of the depression could potentially benefit from the medication in addition to the psychotherapy. And obviously we've seen a lot of the patients who have been willing also to really take both medication as well as being engaged in therapy. We need to keep in mind in patients who have a co-occurring substance use disorders that the medication piece might not be really enough, obviously, even and really focus the recovery work on incorporating the interventions, the psychotherapeutic interventions that would target the depression as well as the substance use. In terms of what we know, if we can go back to the psychotherapeutic approach, psychosocial treatments, you see here the different treatments, variety of treatments that really work, the cognitive therapy, the interpersonal psychotherapy, obviously the supportive therapy, and an adaptation modification of the psychoanalytic treatment, which is really dynamic therapy. And obviously there's a lot of what we try to incorporate now, a lot of the psychoeducational approaches, a lot of the skills, social skills training. In terms of the medications, And we have a different variety of medications now. We have more and more medications that we can use, whether we're talking about the SSRIs, the tricyclics. We have the newer antidepressants that are used, keeping in mind that some of the medications require monitoring of the blood levels to make sure that patients are on the adequate dose, and also keeping always in mind that patients would need to take the medications for an adequate period of time, otherwise they wouldn't work. And always really remembering that, educating the patients about how medications work, what to expect from medications, and also what to expect from really the psychotherapeutic approaches, and how the combination of medication and psychotherapeutic approaches could really optimize a better outcome. And always remembering that any sort of a substance use that in the context of patients who are taking medications could potentially jeopardize the impact or reduce the impact of the medications, as well as also lead to some serious substance use drug interactions that could really also be very much problematic. Again, I mentioned that a little bit earlier, that in terms of really how to really determine whether patients would want to be on medications, or whether they would need just medication or just psychotherapy. This is here a little bit of more of a recap of what I mentioned earlier. Always remembering in the severely depressed patients, the combination of medication is required to ensure positive outcome. And this is really also another recap of what the areas of focus that could be looked at in therapy is. Mentioned some of it, obviously the interpersonal issues, the cognitive distortions, and obviously always remembering the psychoeducation is extremely important. That would address also a lot of the lifestyle issues, the structuring, also keeping in mind that we know now more and more that physical activity could have a significant positive impact on the depression, and also always remembering that integrating the treatment in patients who will have substance use disorders co-occurring with the depression, providing a dual recovery model that integrates the treatment of both the depression and the substance use disorder. These are some of the things that I mentioned really earlier, and always remembering that the areas that need to be assessed on a regular basis, and the suicidality, and also remembering the importance of the social support system, and always also important to remember the involvement of family and concerned significant others in the treatment. This is the slide that covers some of what I mentioned also earlier, is that the importance of really the physical activity and its impact on the mood, and even exercise can enhance feelings of well-being without increases in the cardiovascular fitness, which means there are different types of ways to really be involved in physical activity, and remembering that the physical activity can have a significant impact, and the impact could be also long-lasting.
Okay, we're going to switch to grief and just talk briefly about some strategies, because many people with addictions have lost significant relationships. There are many losses related to addiction. You have loss of stability in living situations, loss of jobs, loss of self-esteem, loss of sense of self. Loss of your addiction is a major adjustment as well. You no longer have that drugs or alcohol to rely on. But we want to talk here more about losses and grief vis-a-vis interpersonal relationships. And you do have lots of losses. We have some patients, for example, who are involved in lifestyles in which they lose a lot of people. And not only do they lose friends, I mean, we all lose people, but they may lose friends in their 20s or 30s, because of a lot of it's drug deals gone bad and inner city violence and things like that. But the other side of that too is, and we haven't spoken much about this because we're talking more from the point of view of the patient in treatment or the client in treatment for addiction, is that family members have grief as well, because we had we were doing a pilot study on traumatic grief in one of our inner city clinics, and we had a number of parents who lost young men to prison. They went to extensive prison terms because they shot and killed somebody. So they'd be, they might have a lifetime sentence, or they might have a 20 to 30-year sentence or something like that. And so we, a couple of years ago, actually about 8 years ago, Dr. Douaihy and I worked together and reviewed some of the literature and wrote a grief journal to help people with grief. And part of it was personal because I lost my wife of 30 years to cancer, over a 16-month period. And so what we did is we put together just some strategies based on what we knew, what we learned, and what the literature said. So these are just some of those briefly. One is to get people to share their story of loss, accept and share their feelings. And you may have a range of feelings, not just, there may be sadness, there may be depression, there may be anger that you lost the person, there may be anxiety about how am I going to cope without this person, there may be relief. Maybe the person you lost had a significant debilitating disease and you hate to see that suffering. Listen to other people's stories, and this is why 12-step programs work so well. People listen to each other's stories, they learn from each other. I think the same happens with grief. It's amazing when you lose someone how many people will tell you their stories. And I heard one story that I heard a lot of stories that really touched me deeply. But one of the women I've worked with, never met her, just worked with her by phone, a publisher, told me about losing her, going on vacation a number of years ago, several families on a summer vacation, and the men went fishing and the women went shopping, and in front of her, in a small town on the sidewalk, a drunk driver came on the sidewalk. He'd killed her 6-year-old daughter and a 61-year-old mother in front of her. And, you hear stories like that. It's just incredible what people go through. Seeking support from family and friends. Sometimes when we're in a sense of grief, we don't reach out. We need people to reach out for us. And when I was going through my toughest period early on, people often want to have the right thing to say, the perfect thing to say, and there is no such thing. Being with is probably more important than what you say. Or even things like this. I learned this from a colleague who shared her grief with me and started to do some of this stuff, even sometimes doing practical things like cleaning somebody's house, paying their bills, doing things for them to help them get through some of the day-to-day stuff. So I was going to invite Dr. Douaihy over to clean my house, but he said, you lost your wife 8 years ago. What the hell are you doing now? Being active, but also being alone as well. Reflecting on your loss, paying tribute to your loved one. There's lots of different ways you can do that. And I think, you all probably have some ideas. Taking care of your health, using your spirituality, religious belief. It's a great relief for many people. Modifying your home environment. I made some changes. I always like to tell you learn something about your spouse sometimes when things, unfortunately, things like death happen. But when I traveled a lot, and I used to always go to Victoria's Secret and buy my wife a pair of these sexy underwear and send it in the mail with a little racy note. And in one of her drawers at home, I found like 114 pairs. And I couldn't get rid of them all, so I kept some. And I don't wear them, so just so you don't, go there anyway. But that was just one thing, like getting rid of some of the stuff, but also keeping some stuff as well. Writing is very helpful. Journaling helps people with lots of issues. I kept a journal during my wife's illness, as well as probably the first year or two after I lost her, and that was very helpful. I have hundreds and hundreds of pages. Some of it I can go back and become very emotional because I can picture where I was. I remember, for example, 3:30 in the morning outside of her hospital room, the night she went into a coma 2 days before she died, and I could picture myself outside of her room writing, and I remember what I wrote. And when I go back and read it, it hits me. But very importantly for parents to help your children as well, because it's very hard on children, very hard, even young children. Even young adult children have difficulties as well. And there's a lot of good resources on grief as well, a lot of good web pages. And what I found very helpful is David Kessler, who actually wrote a book, I think, about Elizabeth Kubler-Ross, wrote a phenomenal book on grief and grieving for the person left behind. So I found a lot of this very helpful. Briefly, guilt and shame are very common. Guilt is I feel bad about what I did or didn't do. Shame is I feel bad because I have a disease or I'm defective, there's something wrong with me. And these are common among people with psychiatric addiction or dual disorders. And this is where I think Dr. Volkoff has done a phenomenal job helping us think differently in promoting addiction as a brain disease. It helps people move away from the belief that I'm weak or I'm a failure, looking at how drugs interact with your brain to cause you to become dependent on them and to have, even when you quit, it may take a long time for your brain and your body to adapt to being without drugs, which may mean that you crave them, you want them, that sort of thing. It's some of the common behaviors we see: not being responsible, not fulfilling obligations, taking advantage or lying to others, failure to support the family, committing crimes. They go with addiction, and obviously a lot of that stops when people get sober and clean and into recovery, but not always. You still can have people who can be sober and clean and not responsible in some of their roles in life. But guilt and shame are very common, and we also find with co-occurring psychiatric combined with addiction that people feel almost sort of like double shame, like I can't believe I have all these disorders. And we try to promote the idea that these are no-fault illnesses or diseases. And this is why it's important, the teaching part's important, about teaching about illnesses, like what are the causes, what are the effects, what are the symptoms, and what are the treatments. And then we really promote taking responsibility for recovery, but not judging yourself for having a disorder. And then some of the coping strategies, again, recognize, accept these feelings, taking time. There's no quick fixes. One thing I've learned over the years, there ain't no quick fixes for nothing. Things take time. Getting people to share is important. Using 12-step programs, a number of the 12 steps really help people with guilt and shame. You have the inventory, you have, admitting to another person and to God or your higher power the nature of your wrongs. So there's a lot of stuff within the 12-step program that's incredible. And the other thing, too, that I think is, and I want to use an example that is more from the point of view of a family member, not the point of view of someone with an addiction, but I think the concept applies, which is you can share anything at these meetings and people understand. You can share crazy things. And there was a woman once at a meeting, and if you heard this outside of the context of a meeting, you'd say there's something wrong with this woman. And she talked about she made a list, and the list was 100 ways to kill my husband. She had an addicted husband, and she was frustrated. She had it. Now, if you're in Al-Anon and Ar-Anon, you understand that. You accept that. You understand the context of that. Whereas if you're not, you think there's something wrong with the woman. But the 12-step programs are tremendous, tremendous source of support for guilt and shame. And then seeking forgiveness for others. But I think, you can't rush that. And I believe steps 8 and 9, the making amends steps, are a great way of moving towards that. And my experience has been typically family members are more likely to forgive the addicted person than they are. They're more difficult with themselves. They're more harsh on themselves. Briefly, a few other things. Boredom. It's very common. It's a high-risk factor for a number of reasons. It can be sort of in general. It can be related to recovery. People get bored with recovery, want the meetings over and over again. They get bored with work. They get bored with relationships. They may want to quit their job without another job because they're bored. They may want to stop a relationship. They can't deal with the ordinariness of it. So there's lots of different types. And typically in the program, people are encouraged not to make significant changes until they have some stable periods of recovery. So you want to help people look at what are the reasons, what is the type of boredom, and in a practical sense, how do you regain lost activities that didn't evolve around drug or alcohol use, with the caveat that some people will not be able to do this easily. They may not have anything of interest that doesn't focus around using substances or being in situations where people are using it. Part of this, too, is, excuse me, appreciating simple and ordinary things in life, developing new interests. We often in treatment will have people make a list of things they enjoyed before they became addicted, and then put an X through the ones they gave up because of their addiction. And it's normal stuff. It could be, playing sports. It could be jogging. It could be, playing board games with family or friends. It could be simple things. New interests, having fun in daily life. if you look at the treatments for depression, they all focus on pleasant activities. People have to have enjoyment. Also helping people know what are their high-risk times for boredom, and changing some of their thinking about boredom and activities, because you have some patients that feel like they can only be engaged in life if they're at some high level of activity. They just need this, this adrenaline rush. So be careful about major changes. Deal with persistent feelings, support groups. If people can find something to feel passionate about, it doesn't matter what. It does not matter what. It's just that I feel passionate about this. And then refuting some of the thoughts before they decide to use. Okay? Then the last area we want to talk about briefly, and I think in the future, and we're going to move this up because we always sort of run into time things, but is focusing more on positive feelings. And the good thing about, I think, 12-step programs is they will do this. Professional treatment tends to focus more on negative feelings. In fact, those of you who are psychologists should know that about a dozen years ago, this whole movement started in positive psychology. And I just heard from one of our attendings today who got a note from the head of the American Psychiatric Association that she wants to focus on positive psychiatry, which is good. So these are some of the positive emotions. And different people have done different research in this, but there's one, Barbara Fredrickson talks about the need for at least 3 to 1, 3 positive feelings for 1 negative one for healthy functioning. And clearly, the more people feel positive emotion, the better they're going to feel physically. They're less likely to have chronic conditions. They're better able to fight off disease and illness, better quality of life, better relationships, and perhaps they'll even live longer. But we all know this. We all know that if you feel good, you enjoy life more. Being with spending time with important people. Spending less time with negative people, because there are some people. I think of I can't believe this. I'm going to tell you this. I had a grandmother, and grandmothers are usually pretty damn cool. We like being with grandma. I mean, they're sweet, they're kind, they cook good, they give you stuff. They're just cool people to be with. But I had this grandmother, and she was a miserable old coot. I mean, I'm talking miserable. Now, the thing is, she lived till she was about 95, and you'd say, "Hey, Grandma, how you doing?" And she'd start going through a litany of physical complaints. She was psychosomatic beyond belief. But the point I wanted to make here is it's an extreme example, but there are people, if they're too negative, it's harder to be around these. And I think for people in recovery, it can pull them down. Making positive statements, showing positive emotions through actions. You can say things. You can say, "I love you," and not show it in your actions. Or you can not say, "I love you," and you can show your love through your actions. And I recall having some of my best discussions in treatment groups with veterans in particular about issues around love and relationships. Gratitude, be thankful and be ready to show appreciation and return kindness to others. You have personal gratitude for what people do for you. You have transpersonal, which is might be to God or a higher power. Same thing, gratitude, you feel better, you have better experiences. Grateful people do better in life in terms of health, satisfaction, longevity. And these are just some strategies here. You have to look for this. And I think we've become too much of a negative society and culture that we take this stuff for granted. You're more likely, you've heard the term, the squeaky wheel gets the grease. You're more likely to hear about problems and difficulties than you are good things happening. And I can assure you, when you get patients to talk about positive emotions and things like gratitude, they light up and they like it. I think they feel better because they think they don't have this. You have to make them look for this. So these are just some ways, you want to show it in your language, you want to show it in your behaviors. Just like anxiety thoughts or depression thoughts, you have to fight these off and replace them. You don't want to take people for granted. I mean, we often do, and it happens. I mean, my adult kids take me for granted. I take other people for granted, but you want to, as much as possible, appreciate things, even small gestures, because I've seen lots of nice things that people do for others. And the other thing, too, is a lot of people talk about don't see yourself as a victim. No matter what you've been through, you want to develop resilience so that you can get over this, whatever it is. So we're going to stop here just to see if you have any questions.
Dr.
Thank you.
Daley, we have some questions.
Yeah, I did. I missed some. Can you talk?
And as a reminder for audio questions, please press star then 1 on your touch-tone phone.
Yeah, I'm going to start with, can you talk about effective treatments with substance use and bipolar disorders, including medications, behavioral therapies, and family interventions?
Okay, well, this is a very good question. Unfortunately, there has not much been done with patients who have bipolar disorder co-occurring with substance use disorders. I'll focus a little bit on the medication piece. Obviously, we don't have any particular medication that has been necessarily in a way approved, to be used in that context. We've done a study in our clinic that looked at the use of the valproic acid, Depakote, as really a treatment for patients who are bipolar, who have bipolar illness as well as substance use disorders. I'm talking about alcohol dependence. And interestingly enough, that the treatment was more lithium as a baseline, and on top of it, people receiving Depakote versus people not receiving Depakote, and which is the valproic acid, as I mentioned. And in fact, one of the things that we've noticed with the study, which was published in 2005, is that it did control whether people are on Depakote or not Depakote. Symptoms were controlled, whether we talk about the depression or the manic symptoms. And what is really very interesting is that the patients who were on Depakote, they have done better in terms of reducing alcohol use, whether we talk about heavy drinking days or number of drinking days. And so the Depakote is really very much promising in that context. And usually when we're using mood stabilizers in the context of patients who have substance use disorder and bipolar disorders, my preference, and from what we know that works, I would really go with the first-line treatment using the valproic acid. And obviously lithium still does work, particularly mostly for the depression piece. Mostly, in fact, there are a lot of patients also who are really taking a combination of both, lithium and Depakote. Some patients would require also other mood stabilizers, that particularly, for example, lamotrigine, which really focuses more on the depression side of the bipolar. This is what I meant, not the lithium. So in terms of the psychosocial treatments, obviously integrating the treatment of the substance use as well as the bipolar illness is really the best way to go. And in fact, we also did a study that we incorporated what we call the treatment using motivational strategies, psychoeducation, relapse prevention, as well as really treatments for the bipolar illness. And most of the focus was in our study was on the adherence treatment, because a lot of the problem that we see, a lot of the challenges that we see with patients with bipolar and substance use disorders, they have a tendency to stop taking their medications, not stay in treatment, or obviously relapsing on substances and continuing in this vicious cycle. So most fundamentally is also working with patients on adherence strategies in that context would be very, very much crucial, because we want to make sure patients are taking their medications consistently, at the same time staying clean and sober, and basically also being involved in treatment and attending mutual help groups. So if we look at it from what we call the three-legged stool dual recovery principles, so you have three pieces, three components to it: the staying clean and sober, adherence to medications, as well as adherence to treatment and mutual help groups.
Yeah, just a couple comments I'll add. Roger Weiss from Harvard recently published a book on integrated treatment for substance use and bipolar disorders using a group model. It's a kind of a structured 20-session model. You can take a look at that, because they have a curriculum where they focus on both addiction issues and bipolar issues. Two other questions I wanted to get to briefly. One is, would you please introduce a manual for 12-step programs? If this is what I think it means, there are treatment manuals. There's 12-step facilitation. NIAAA published a manual from Project Match. Kathy Carroll and her group at Yale University, they adapted this to use with drug addiction. So they have this available, this manual on one-to-one treatment. There's also a 12-step facilitation project through Hazelton Publication that has the materials and has the framework for the model and so forth. And then we just finished in the Clinical Trials Network a study of 12-step stage 12, and we did work on a manual for that, which involves both individual and group treatment combined. So there are resources for 12-step counseling if that's what you're looking for. Okay, one other question before we finish is, can you explain what teach sleep hygiene means? We can't do this justice in a minute or two, but keep in mind a couple things. One is that a lot of people have trouble with sleep, and if you don't get good sleep, you're tired. It can certainly affect your health. It could affect your mental state. It could affect your emotional state. It could affect your recovery. And by sleep hygiene, we're talking about helping people figure out what are some ways to structure how they deal with these things. You know, so for example, if you're having trouble falling asleep and you're drinking coffee before you fall asleep or cola with caffeine in, you know, you want to take a look at this. You want to take a look at how can you get people to prepare to go to bed, to have regularity in terms of when they go to bed and when they get up, things like this. And there's a lot of different resources available to help teach this. There are also medications available too. What you want to do is you want to be careful about avoiding addictive medications where people depend on these, you know, to get to sleep. So sleep hygiene really refers to a general strategy of getting people to think better and do some behavioral changes to increase the likelihood that they'll be able to sleep through the night and get good rest.
I'm going to answer that question quickly. Is there a synthetic oxytocin available? Yes, indeed. There is. It's called Pitocin. And yes, it is available. I'm trying to really remember here, you know, what the indications are. Honestly, I believe the indications are more in the OB-GYN, you know, settings. So this is where it is used.
Like for attachment or something?
You know, I think it's really more for... as we know, basically, it's as I discussed earlier, that it has a role in the sexual reproduction, particularly during and after childbirth, and it does obviously facilitate birth, and it's after really stimulation of the nipples, it facilitates breastfeeding. So, and obviously, a lot of really what's been looked at, you know, there are more and more studies that have looked at investigating its role in anxiety, or the orgasm, you know, and maternal behavior. So this is what I'm aware of. I mean, it was referred to as the love hormone.
We have, in case you're interested, just send me an email. Put together references on a lot of these different interventions and different problems related to feelings, emotions, and mood disorders. And there should be, I believe there should be some stuff on sleep in there as well. So if you send me an email, make sure you get that bibliography. It's about 5 pages. So thank you all. We really appreciate the time together. We hope that you found this useful. We had a lot more to cover than we could cover, and we'll look forward to working with you again. So thank you, Tracy.
Thank you.
Thanks, everyone, for attending. You can send an email to ctntraining@ms.com to reach Dr. Douaihy and Dr. Daley, and then we can forward that along for you if you have any additional questions. Thank everyone, and this is the end of the call.
Thank you for participating in the Managing Emotions in Recovery webinar. This concludes the webinar for today. You may all disconnect at this time.
Dennis?